Hello everyone. Today we'll discuss about special senses. What is this special senses? The special senses are nothing but the senses which are specialized by the telereceptors like vision, hearing, audition, okay, and smell, taste. Okay, right. These special senses are mainly the sensation or the complex sensation which involved in the special sense organs is called as special senses. These sensations different from the somatic sensation and arised from the skin, muscles and the tendons and the joints. These sensations mainly about four types. The special senses mainly about the four types like sensation of vision, sensation of hearing, sensation of taste, and sensation of the smell. All these four comes under the special senses. These are without any joints, without any muscles and without any somatic sensation. These are worked out. That's way. So by a special type of the organs, a specialized organs, that's why these are called as special senses. In that we have vision, hearing, smell and taste. And first come to the sensation of the vision. What is this vision? Vision by the whatever we are seeing. By a specialized organs that is called as eye. This eye, if you see the structure of the eye, so what are the parts involved in the eye? First, pupil, conjunctiva, the white part, cornea. The pupil is ball letters, eyeball. In the middle of the eyeball, there is a presence of the pupil. Pupillary muscles are present in that. Conjunctiva, cornea, front part it is, and ciliary muscles. So by which we can move easily our eye. Eyeball is moved by the ciliary muscles. This is the front part of the eye. And if you see the back of the eyeball, there is a glass. That is visual glass is adjustmentable and the flexible glass is present. That is called as a retina. This retina, so whatever we are seeing, that image falls on the retina and through the different nerve fibers, and it sends that information through the nerve fibers which are called as optic nerve. And if you see, the eye is completely attached with the muscles is called as superior rectus and the inferior rectus. And after that, if you see the eyeball, there are some walls are present. 3 walls are present in the eyeball. The first one is the outer layer is called as tunica externa. And the middle layer is called as tunica media. And the inner layer is called as tunica interna. Tunica externa, outer layer, tunica media, middle layer, tunica interna, inner layer. And first come to the outer layer. Outer layer is with the cornea and sclera. And this cornea contains stratified epithelium and the sclera contains fibrous tissue and the elastic tissue. And come to the middle layer. In the middle layer, the choroid plexus are present and the ciliary body and iris is present in this. And if you see the inner layer, tunica interna, so that layer of retinitis, it is the layer of retina. So in this, the layer of the pigment epithelial cells are present. And next one is the layer of rod cells and the coat cells. So these are the receptors of the light rays. and the image. Rod cells and the cone cells are the receptors of the image by the telereception. And next one is the outer nuclear layer is present. Later on we'll discuss what are the layers in this present. Totally 10 layers are present in this. Okay, if you see that layers, there are totally 8 layers are present, and the 2 are for the external and the internal layers. And if you see from outer to inner, the first layer is called as layer of nerve fibers. And next one is layer of ganglion cells. And next one is inner plexiform layer. And after that, inner nuclear layer. And next is outer plexiform layer. And after that, outer nuclear layer. And the final one, layer of rods and cones. So which are the receptors of this. After that, the pigment epithelium is present. Okay, and if you see the fluid in the eyes, there is fluid is present. That fluid is called as intraocular fluid. It is called as intraocular fluid. This intraocular fluid is nothing but it is also called as fluid of eyeball, and it is responsible for the maintenance of the shape of eyeball. This fluid is responsible for the shape of eyeball. And this intraocular fluid is in 2 types. One is vitreous fluid and another one is aqueous fluid. Vitreous humor and another one is aqueous humor. The vitreous fluid is the external fluid and the internal fluid is aqueous humor. And this vitreous humor is the viscous fluid which is present behind the lens. Which is present behind the lens, that is called as vitreous humor. And aqueous humor is the thin fluid present in front of the retina. And it fills the space between the lens and the cornea. And next one is, so after this, the properties of the aqueous humor, so which fills the space in between the retina and the middle layer. If you see the properties of this, the volume is about very less, that is about 0.13 ml, 13 milliliters, 0.13 milliliters it is. And next one, if you see the reaction of this one, it is completely alkaline and the pH with the 7.5. And the viscosity is about 1.029 and refractory index is about 1.34 it is. And if you see the composition of this aqueous humor, internal fluid in front of the retina, okay, so water is about 98.7% and the solids are about 1.3%. And these solids, water is water, that's it, there is no further dividation, and the solids are divided into 2 types. One is organic substances and next one is inorganic substances. And come to the organic substances like albumin, globulin, glucose, lactate and urea. Pyruvate is also present. Okay, and next one is, in case of the inorganic components, anions, cations like sodium, calcium, potassium, magnesium, chlorides, phosphates and bicarbonates. This is the composition of the aqueous humor. And next, if you see the muscles which are present in the eye is called as ocular muscles. These ocular muscles, so if you see the muscles of the eyeball, this one is intrinsic muscles and the extrinsic muscles. 2 types of the muscles are present, intrinsic muscles and the extrinsic muscles. And if you see the intrinsic muscles of the eyeball, there are 3 types of the muscles are present, that is the constrictor papillae and the dilator papillae and ciliary muscles. constrictor papillae, dilator papillae, and the ciliary muscles are present. And if you see the extrinsic muscles, there are in 6 types. The extrinsic muscles are in 6 types. If you see that the superior rectus and the inferior rectus and the medial rectus, and next one is lateral rectus and superior oblique muscles and the inferior oblique muscles. So by which we can move our eyeball very clearly. All these are the extrinsic muscles. If you see this diagram, you will come to know the muscles, how it works. Lateral muscles, sides, and the superior muscles, upper part, inferior muscle, downwards, sides, abductions, elevations. Okay, so and all this, and if you see the how we can move our eye, in the sense, if you see this diagram, so we'll come to know very clearly. So the upper side movement of the eyeball is called as elevation, and the lower side movement of the eyeball is called as depression, and the lateral side, that is called as abduction. It is. And next one is, if you see the movement and what are the muscles involved with this, in case of the abduction, so in case of the abduction, the primary muscle is lateral rectus, and the secondary muscle is superior and the inferior oblique muscles. And next movement is adduction. In case of the adduction, the medial rectus is the primary muscle and the superior rectus and the inferior rectus are the secondary muscles. And next one, elevation. If you see the elevation, the superior rectus is the primary muscle and the inferior oblique muscle is the secondary muscles. And after this, the depression, in case of this, the primary muscle is the inferior rectus and the secondary muscle is the superior oblique muscle. Okay, and next one is for the extorsion. For that, inferior oblique muscle is the primary muscle and inferior rectus is the secondary muscle. And intorsion. So for this, superior oblique muscle is the primary muscle and the secondary muscle is superior rectus muscle. And for all this, there are so the layers, so we can come to know very clearly 2 types of the cells are present which receives the light rays and the image rays. So that is what the rods and cones. Rod cells and the cone cells. And in this rod cells and the cone cells, okay, these are the receivers or the receptors of the image. This is the cone cell and this is the rod cell. It is image perception by these 2 types of the cells, rod cells and at the same time cone cells. Okay, and next one is the adaptation. So one is light adaptation and another one is dark adaptation. What is this light adaptation? So when from the dark area to when we are entering, when a person entering from the dark area to into the light, immediately there is an adjustment of the lenses and the person cannot see anything for few seconds. After some time, the muscles and the receptors and the image and the retina, everything is adjusted to that light and then the person can see anything. That is called as light adaptation. And next one is dark adaptation. The best example for this dark adaptation is cinema theaters. So when a person enters from the light into the dark, nothing is visible there. In the theaters, nothing is visible there. After some times, there is adjustment of the lenses and the muscles and the receptors and the retina. And then the person can see everything. Seats, persons, human beings and whatever is present. Like that, the dark adaptation is nothing but when a person enters from the light into the dark area. For few seconds, nothing is visible, and after some time, there is adoption or the adaptation of that particular area into that adapted to that dark area, and everything is visible. That is called as dark adaptation. And visual acuity. What is this visual acuity? Whatever we are seeing, whatever we are observing, that should be clear. Isn't it? Okay. So that is called as acuity, accuracy of vision. That is what visual acuity. As we know, so if you go to the eye specialist, so then there are some charts with the A, B, C, D letters, isn't it? Okay. So those are in different fonts. That is called as a distance for the distant vision. So that is called as Snellen's chart. The chart is called as Snellen's chart. It is only letters are present in different fonts. And the normal visual acuity in the distant vision is about for the 6 meters, it should be about the 6 font. 6 size of the font should be read. That is called as 6 by 6. It is normal visual acuity for the distant vision. And another one is Jagger's chart. Is a words are present in this Jagger's chart. And if that, so that is in between the 15 to 20 centimeters from the eye length. Okay. So, and if there is the proper reading in the sense, that is for the near vision. That is called as Jagger's chart. Okay. For distant vision, Snellen's chart, and the near vision, Jagger's chart. And next one is field of vision. How much amount of the area we can observe is called as field of vision. This field of vision is different from the right eye to left eye. If you close right eye, so if you close this right eye, so what happens? Some of the area is missed with the binocular vision. And if you see with the both eyes, so we can come to know from this to this area. So whatever the area is covering, okay, that is called as field of vision. This field of vision is majorly in 2 types. One is binocular vision and another one is monocular vision. Binocular vision is nothing but with help of 2 eyes, and the monocular vision is nothing but with help of only 1 eye. In case of monocular vision, it is distinct from the each eye to another eye. The field of visions are individual for the both eyes. In case of monocular vision, okay, and if you see this divisions, there is temporal and nasal fields. Temporal fields in the sense lateral letters, sides, and the nasal vision in the sense inner part towards the nose is called as nasal vision. And the another one is upper and lower, upper part and the lower part. Including of all these, temporal, nasal, upper, lower, including of all this is called as divisions of the visual field letters. And next one is the corresponding retinal point is the diplopia. And diplopia is nothing but double image. So all are come to the retinal point only. If the monocular visions are worked out there, in case of binocular vision, the image falls differently on the retina, and there is that single image falls on the 2 sides, and then there is the diplopia. That is what double image. And next one is, so the field of vision and the retina is this is most important on the falling of the image on the retina, and the mapping of the visual field is by the perimetry is an instrument by which we can observe the visual field. And if you see so all these parts, so we'll come to know the nasal field and the temporal field and the upper field and the lower field. And next one is the pathway, visual pathway. So what is this visual pathway? How we are seeing, how we are observing. So we know till the eye and immediately we are observing that image. And inside of the eye and inside of the brain, so much things are happening by the different types of the neurons. There are three types of the neurons: first order of neurons, second order of neurons, and the third order of neurons. And when the image falls, this is the pathway, and if you see the sequential diagram of the same pathway, it is like this. Visual receptors in the retina is the perceived the image, and immediately the first order of neurons, that is the bipolar cells, receives that image, and it sends it to the second order of neurons, that is the ganglionic cells. And through the ganglionic cells, that rays of image falls on the retina, and then through the optic nerve, it sends to the optic chiasma. So where from the, it is a junction, optic chiasma is a junction of the, so both eyes. So the optic nerves comes from the right eye individually and the left eye individually, and these two comes together and meet at a junction. So that is called as the optic chiasma. There are different fibers as present in the optic nerve: temporal fibers and the nasal fibers. And these nasal fibers are responsible for the temporal vision, and the temporal fibers are responsible for the nasal vision. And after this, so after the optic chiasma, through the optic tract, third order of neuron, that is through the lateral geniculate body, it sends that information and the optic radiation. Through that optic radiation falls on the visual cortex. And if you see the areas in the visual cortex, this visual cortex is present in the cerebral cortex. It is the highest center for the vision. It is called as visual cortex it is. And in the visual cortex, there are three types of areas are present. That is nothing but area number 17, which is also called as primary visual area, and the secondary visual area, that is area number 18, and area number 19, so which is also called as occipital eye field. Nothing but visual cortex it is. Three areas are present. The primary visual area, which is responsible for the perception of the visual impulses. And next one is the secondary visual area, which is responsible for the interpretation of the visual impulses. And the third one, area number 19, which is responsible for the movement of the eye. And so during this, some of the hemispheres or hemianopias are present. If the one side of the eye is blind and second side is another one, through the nasal field, how it is goes, and there is hemianopia, homoanopia. So all these are, and complete blindness in some of the people. So different cases are present. And next one, if you see the effect of the lesions, are mainly concerned with the, if you see the previous diagram, so this is what that, okay, and here it is concerned with A, B, C, D, E, isn't it? Okay, so till G, and in that the A is concerned with the lesion at the left optic nerve, and the B is lesion at the right optic nerve, and the C is lesion at the lateral fibers, and the D is lesion at the lateral fibers and the right side, and the C plus D is nothing but the lesion at lateral fibers in both sides, right and left. And E is concerned with the lesion of the middle fibers of the optic chiasma, and F is lesion at left optic radiation, and the G is lesion at the right optic radiation. Next one is visual defects. If you see the visual defects, there are two types of the visual defects are there. One is anopia and another one is hemianopia. Anopia is nothing but blindness. Hemianopia in the sense partial blindness. Anopia is in two types. One is right anopia and another one is left anopia. Right anopia in the sense right eye is not visible, and the left anopia is nothing but the left eye is not visible. And if both are not worked at all, there is no visual perception, and that is called as anopia, complete blindness. And another one is hemianopia, is in the sense partial blindness it is. If you see this partial blindness, that is in two types. One is homonymous hemianopia and another one is heteronymous hemianopia. Homonymous hemianopia, heteronymous hemianopia. First come to the homonymous hemianopia. This divides into two types. One is right homonymous hemianopia and another one is left homonymous hemianopia. Either the temporal part or the nasal part. Any one of this is not worked. That in the sense, temporal vision is not worked at all, or the nasal vision is not worked at all. That in the sense, if the temporal visions, that both temporal fibers are not worked at all, that in the sense it affects on the nasal vision. And another one is if the both nasal fibers are not worked at all, then it goes for the temporal vision is not worked. That is heteroanopia. And in case of homonymous hemianopia, either the right side of vision is not visible or the left side of the vision is not visible. And the second one, come to the heteronymous hemianopia, is in two types. That is, one is binasal heteronymous hemianopia and bitemporal heteronymous hemianopia. In case of binasal heteronymous hemianopia, the nasal fibers, that in the sense nasal fibers are not worked at all, that is the bitemporal, and the temporal fibers are not worked at all, then the nasal vision is not worked at all. Temporal fibers, nasal vision, effects on the nasal vision, and the nasal fibers, effects on the temporal vision. Where in case of the binasal heteronymous hemianopia, the nasal fibers are not worked and the temporal vision is affected. After that, bitemporal heteronymous hemianopia, so that is the nasal fibers are not worked at all, not functioning properly, and the temporal vision is affected. And next one, if you see the pupillary reflex, according to the light adjustment, the pupillary muscles are moved, and there is abduction, adduction, and the elevation and the depressions. Like a camera lens, how it is moved, the pupillary muscles are moved like that. If you see these reflexes, so when the light rays falls on the eye, immediately the optic nerve, through the optic nerve, this information sends through the optic chiasma and optic tract. Through the optic tract by the lateral geniculate body, so it goes to the pretectal nucleus. It goes to the pretectal nucleus, the impulses. When the impulses passed from the pretectal nucleus, there is a nucleus that is called as Edinger-Westphal nucleus. Through the Edinger-Westphal nucleus, the ciliary ganglion gets activated and it gets the mood. And by this movement, immediately short ciliary nerve take that impulses and there is contraction and constriction of the pupillae. That is the pupillary reflex. And next one, if you see the both accommodation reflex and the pupillary reflexes. Through the visual pathway as it is, so the information sends to the visual cortex by the eye, optic nerve, optic chiasma, optic tract, lateral geniculate body and the optic radiation and to the visual cortex. Till this is the visual pathway. After this, visual cortex in the area number 17, when the impulse is passed, where the image perception occurs, that is the area number 17. In the area number 17, it sends that information to the area number 8, that is what the frontal eye field. And through the frontal eye field, it sends information to the different kinds. For the accommodation reflex separate and the pupillary reflex separate. If it want the pupil constriction or the pupillary reflex, then Edinger-Westphal nucleus gets activated and the impulse is received by the Edinger-Westphal nucleus for the pupillary action. And by that ciliary ganglion and short ciliary nerve, through the short ciliary nerve, it goes there and there is constriction of the pupillae and the contraction of the pupillary ciliary muscles. When there is contraction of the ciliary muscles, there is increase in the anterior curvature of the lens. The visual area, visual field is more. And when there is contraction of the constrictor papillae, then there is the constriction of the pupillae. The visual field is decreased. And next one, in case of the accommodation reflex, so after the impulses passed on the area number 8 after the visual pathway, and the somatic motor nucleus of the third cranial nerve, and through that there is a contraction of the medial rectus and the convergence of the eyeball. Movement of the eyeball occurs. This is the accommodation reflex. And next one is, if you see some of the peoples, there is vision is proper, but that particular person can't observe the colors. That is called as color blindness. This color blindness is mainly in 3 types. One is monochromatism, another one is dichromatism, next one is trichromatism. In case of the monochromatism, the rod monochromatism and the cone monochromatism. In case of rod monochromatism, rod perception, rod receptors are not functioning properly, and in case of cone monochromatism, these cone cells are not worked properly. That is monochromatism. And in case of dichromatism, there is in 3 types. One is protanopia, and another one is diatanopia, and next one is tritanopia. And after this, trichromatism, in case of this, protanomaly and diatonomaly and tritonomaly. 3 types it is. That is the color blindness. And next one is errors of refraction. Generally, these errors of refraction easily we can observe in our home, like the old age people, or like maybe the father or mother contains different types of the lenses. You may also. That depends upon the degree of visual field. Where the image is falling on the retina, that is inside of the eye. So this is divides into 4 types. One is emmetropia, another one is anisometria, and next one is astigmatism, next one is presbyopia. And this emmetropia is divided into the two types. One is myopia and another one is hypermetropia. Myopia in the sense short-sightedness. The near object is very clear and the distant object can't clear properly. And hypermetropia is long-sightedness. The long vision, distant vision is clear and the near object is not visible properly. Blurry vision is present. And another one is anisometropia, is nothing but metropia is with the totally blurry vision with both myopia and this hypermetropia. Anisometropia it is. And next one is astigmatism. Astigmatism is nothing but in case of the eye. So the distant vision is not visible clearly and at the same time the near vision is also not clear. That is the astigmatism. And presbyopia is nothing but in case of the old age people, the receptors like rods and cones are not worked properly. So by the age factor, if the myopia and hypermetropia is occurs, that is called as presbyopia. And all these four types are corrected by the concave lenses and the convex lenses. If you see this image, we'll come to know so where the image is fault. In case of the astigmatism, the image is fall too far than the retina. So that in the sense forward it is, forward fall of the image. And next one is in case of the emmetropia, that is normal, and in this, so there are two types of this, and one is myopia and another one is hypermetropia. So in case of hypermetropia, the image fall so after the retina, and in case of the myopia, image falls before the retina. Actually, it should fall on the retina. And next one is, if you see the types of errors and the causes and the corrections. For the myopia, by the biconcave lens, it is short-sightedness, the distant vision is not clear. And another one is hypermetropia, in that is the long-sightedness, in that there is the long sight is clear, and that in the sense distant vision is clear and the near vision is blurry. And for this, there is correction by the biconvex lenses. And after this, anisometropia, that is by the separate lenses for the each type of the, so whatever it is required for the each eye. For one eye, it may be myopia, and another one eye, so that may be hypermetropia, anisometropia. And next one is astigmatism by the cylindrical lens. And next one is this astigmatism is regular astigmatism and the irregular astigmatism, whatever it is, but that is corrected by the cylindrical lens. And presbyopia is corrected by the biconvex lens. Sensation of hearing. This is for the audition. Audition is by the ears. So whatever we are listening, how we can listen, what is our reaction, all this comes under this sensation of the hearing. And if you see the structure of the ear, that is, so we can come to know by this image, the external part of the ear with the smooth cartilage, and that is called as auricle. There is internal drum is present. By that, the information sends to the cochlea, the spring type structure, and the temporal bone, so which is attached to this cochlea, and the endolymphoid ducts. And next, suckle. And next one is ocels in the internal drum. These ocels are present, and the article, so which is present at the vestibular apparatus. And next, after this structure of the this one and how the hearing is possible. Whatever we are listening, that should go to the brain. How it sends that information, in the sense that is called as auditory pathway from the ear to the cortex area, cerebral cortex area. How it sends that information, in the sense through the spinal ganglion by the cochlear nerve. Through the spinal ganglion, the cochlear nerve sends that hearing impulses to the dorsal column and to the ventral column. That's the first order of the neurons. And through the dorsal column of this one, through the ventral columns, it sends that information to the dorsal nucleus again. And through the dorsal nucleus, this sends information to the nucleus of the lateral lemniscus. And through the lateral lemniscus, it sends that information to the medial geniculate body of the thalamus. And through that medial geniculate body of the thalamus, it sends that information through the optic radiation, and finally it reaches to the auditory cortex, which is present in the cerebral cortex. First, spinal ganglia, and through that cochlear nerve, and next ventral group of nucleus and dorsal group of nucleus, and after that nucleus of lateral lemniscus, and through that medial geniculate body of the thalamus, auditory radiation, and the auditory cortex in the cerebral cortex area. That is what the auditory pathway. And next, if you see the defects of the ear and the earrings. Okay, so there are two types of the defects are present. One is conduction deafness and another one is nerve deafness. In case of the conduction deafness, so the person cannot hear properly by so whatever the radiation is presented, so by the cochlear nerve through that lemniscus and the thalamus, it sends to the auditory cortex by the auditory radiation, but that goes separately, and there is different vibrations are present so that the person cannot listen properly. That is called as conductive deafness. And next one is nerve deafness, or the nerve. In case of this nerve deafness, so the ear only can't work properly. Whether it may be the right side, or it may be the left side, or it may be both sides. Through this nerve deafness, so any one of the part, either the first order of neurons, or the second order of neurons, or the third order of neurons, any one of this, the nerve conduction is disturbed and it may be disrupted. That is called as nerve deafness. And for this, there are three types of the test. One is Rinne's test, and the other one is Weber test and audiometry. Audiometry is advanced technology. By that, so we can come to know all the results. And Rinne's test, Weber test are like by the tuning fork test. And in this, somewhat distant maintained by that patient, and the whispering. If that person is listen properly, that is Rinne's test is positive. And the ticking of the wristwatch, if it is just 3 centimeters away from the ear, if that person listen properly, that is that in the sense the Weber's test is that positive, that in the sense there is no difference. The tuning fork test should be, tuning fork should be, vibrate and keep it on the mandible, on the skull. And then if the vibration passed both sides equally, then there is no deafness. If any one side of this is any disturbance, if the vibrations or the impulses pass not clearly, that in the sense deafness is present. On the which side is it is affected. And another one is temporal bone. On the temporal bone, if you keep that tuning fork on the temporal bone, and if the vibrations felt clearly, that in the sense that is no deafness. That is the test of the Rinne's test and the Weber's test and the audiometry. Audiometry is completely advanced test. And next one is sensation of the taste. And in case of the sensation of the taste, how the perception of the taste? By tongue, we know. But how? That is because of the taste buds present on the tongue. The situation of the taste buds and the papillae of the tongue and the mucosa of the epiglottis and the palate, pharynx and the proximal part of the esophagus. Till the proximal part of the esophagus, the taste buds are present. And if you see the structure of the taste buds, so that is like this, the taste pores are present and the type 1 cells, type 2 cells, type 3 and type 4 cells are present in the taste buds. And in these taste buds, the taste pores are the very important, and by this the basal cells, type 1 to 1 cells, type 2 cells, type 3 cells and type 4 cells, all these are very important, and the basal cells and the receptor cells, which are the type 3 and type 4. And all through all this, the nerve fiber, efferent nerve fiber, takes that and sends that information to the cortex area. And how it is, who sends that information in the sense, that is what we call as pathway for the taste. Taste pathway it is. In this taste pathway, so by the taste buds are present on the tongue, and through that it sends that information through the fibers of the facial nerve, glossopharyngeal nerve and the vagus nerves. And next, it sends that information to the first order of the neurons, that is the nucleus of the tractus saltarius. And through the tractus saltarius sends that information to the nucleus of the thalamus, posterior-ventricular nucleus of the thalamus. That is the second order of the neurons. And immediately through that posterior-ventricular nucleus of the thalamus, it sends that information to the parietal cortex. Taste buds to fibers, nerve fibers, facial, glossopharyngeal and the vagus nerve, and nucleus of tractus saltarius and medius lemniscus, and then posterior-ventricular nucleus of the thalamus, and then finally parietal cortex. This is the pathway of the taste sensation. And next one is, there are taste, primary taste sensation. There are 5 types of the taste. The one is sweet taste, and another one is salty taste, and next sour taste, bitter taste and umami. 5 types of the tastes are present, and the taste centers are present in the cortex area and the lower part of the gyrus and the receiver's cutaneous sensation from the face. Thus the taste fibers do not have any independent cortical projections. And the applied aspects of the taste is agousia, in the sense loss of taste sensation, whatever it is. Okay, so if that particular person eat mirchi, then no sensation at all, you won't get anything. Okay, and hypergeusia, in the sense decreased frequency. Taste sensation is present but little bit decreased. And taste blindness is completely loss of the taste. And next one is dysgeusia. That is in the sense. So it may be alters. That in the sense, if that person eats sweet, it may get sour taste, and salt, it may bitter, like that. Okay, so that is dysgeusia. And next one is another one. The last one is the sensation of the smell. In case of the sensation of the smell, so this is by the nose, we know. But how? That is by a pathway, so that is called as taste pathway, sorry, the smell pathway. So how it sends that information in the sense? The mucous membrane is the receptors for the smell in the nose. And through the mucous membrane, it sends that information to the olfactory rods. Through the olfactory rods, it sends that information to the sustentacular cells. Through the sustentacular cells, it goes through the olfactory receptors and the cribriform plate of the ethmoid bone. And through that ethmoid bone, there is olfactory glomerulus, and that olfactory glomerulus sends to the olfactory bulb and to the mitral bulb and the mitral cells, and finally it goes through the olfactory tract to the parietal cortex or the higher centers. See once again pathway. So mucous membrane, olfactory rods, sustentacular cells and olfactory receptors, cribriform plate of the ethmoid bone and olfactory glomerulus, and next mitral cells, optic tract and the olfactory tract and the cortex. And if you see the applied aspects in this, anosmia in the sense loss of the smell sensation, and hyposmia, decreased smell sensation. You can able to smell but decrease. And hyperosmia, more than the normal, is called as hyperosmia. This is what the special senses as per my knowledge. Thank you very much.